okay. If the mic can be on, I love to start on time and make sure we end on time. This session is very compact. We thank Medtronic for sponsoring this session on drug-coated balloons, prevailing game changer in complex PCI. In this part of the world, actually, we're very familiar with the use of drug-coated balloon technology, but we want to enter in a more nuanced discussion into the complex PCI realm when we talk about drug-coated balloon. So the objectives today, you're joining us to drive discussion on the use of drug-coated balloons in complex coronary lesions and high-risk patient subsets, including bifurcations, ACS, STEMI, multivessel disease, diabetic patients, calcified lesions, and we're discussing and expanding the use beyond the traditional indication, such as in-stent restenosis and perhaps small vessel disease. I'm very privileged. My name is Jack. Forgot to introduce myself from the National Heart Centre, Singapore. My spokesperson to my right is Dr. Chew Kim Hui from Malaysia. My discussions on my left include Dr. Sydney Loh, Dr. Frankie Tam from Hong Kong, Naratip from Thailand, Anna Rook on my right, and Sarita is from India, but she's dropping in a bit later. I want to start off the session by Professor Chew Kim Hui's lecture, after which we're going to have more time for a discussion. So please feel free to ask any questions if you have. Kim Hui is going to talk about the PREVAIL SCAAR and bifurcation subgroup data. Thanks a lot, Kim Hui.
Thanks so much, Jack. I'm glad to be here again. So this afternoon, a brief discussion about the role of DCB, especially pertaining to bifurcation lesions, as what is revealed in the SCAAR registry. When we started with balloon angioplasty, we thought we had it made, but there were a lot of problems with dissections and acute vessel closure. Then the stents came in, bare metal, partially sort of stopped the problem, but still have a lot of in-stent restenosis. But when we saw this kind of results with the first-in-man drug-eluting stent, we thought we found a panacea for the problem of coronary restenosis. But in actual fact, then we realized that although we can do it, some people overdo it. This is a true case of a patient with the 47 stents. We thought we could plumb everything. Left main, CTO, bifurcations. It is truly a solution, but it is a solution with additional problem. Problem with late stent thrombosis, caging of the vessel, inflammation, and of course, issues, even with the newer generation drug-eluting stent, every year 2 to 4% TLR creep. So the issue is not settled. Then came the idea that you should then not leave any metal behind. So this idea is correct, to leave nothing behind, and we thought, again, BRS would be the answer. But BRS was not ready for this concept. In the first 3 years, there was more target lesion failure, as well device thrombosis. So we have gone a full cycle, 50 years from balloon angioplasty to DES, BRS, coming back to balloon angioplasty. But this time around, it is drug-coated balloon angioplasty. It is the old and trusted balloon, but it's upgraded. We are now thinking about delivering the drug to do its job, but doing away with issues relating to the metal scaffold. So this idea or mantra of leave nothing behind is really the sort of the main driver for using drug-coated balloon. But beyond that, if you don't cage the vessel, you have the potential for positive remodeling for the vessel after treatment with a paclitaxel-based drug-coated balloon. As mentioned, we are very clear today that there is clear need or use of DCB, especially for in-stent restenosis and small vessel. Because of the application of vessel, the advantages of not using a metal scaffold, we are trying to expand it to other indications from bifurcations, multivessel, CTO, calcified lesions, and even acute coronary syndrome. Friends, not all US presidents are the same, and some are maybe even crazy, I would say. But anyhow, it's the same works with DCB. You have different drugs, but of course, even within the same drug platform, different balloons, different excipient, different drug concentration. So not all DCBs are the same. PREVAIL today has the broadest range of CE mark indications. Beyond just in-stent restenosis, de novo lesions, and small vessel, we have indications to use it for bifurcation, chronic total, multivessel, ACS, and so on. And this did not come about just by chance, because this is a platform that is actually proven to be able to deliver the drug that's necessary to the segment, because it is really one of the best platforms to deliver. In terms of deliverability, is probably one of the best in class. Beyond that, there are, of course, proprietary coating like the free pack that has the right amount of paclitaxel with the right excipient urea to bring in efficient transfer to the vessel wall and a good vessel retention for it to work to allow positive remodeling in the future. Now, the SCAAR registry, if you remember, it's actually from Sweden, Coronary Angiography and Angioplasty Registry. It's probably one of the best, almost 100% enrollment. Well, it's sort of interesting because it was from the SCAAR registry that we realized the so-called early or late stent thrombosis with the first generation DAS also came from SCAAR registry. In this SCAAR registry, it's interesting to note they released their 3-year result in CRT in the middle of this year. There's a very high uptake or usage of DCB in Sweden, nearly 6,500 patients. A lot of DCB is being used, including PREVAIL. They look at the results in 2 years, and interestingly, PREVAIL has about a third of the market share in Sweden. So if you look at this whole cohort, definitely you're not dealing with simple patients, patients with high risk like type 2 diabetes, ACS and multivessel disease. You have patients with a lot of B2 and C sort of lesions, but yet still you have very high procedural success. On top of that, this whole cohort has lots of patients in all these lesion and anatomical subsets. What is clear from this registry observation is that when you use PREVAIL against the other DCBs, there is a low incidence of new myocardial infarction. The p-values may not be significant, but the trend is there. Similarly, with all-cause mortality, all in the right trend, and low event rates up to 2 years. As we expand the indication today, we know we are looking at other things, but in view of the constraint of time, we'll just focus on bifurcation because there is also some data from SCAAR. But we know that drug-coated balloons really has a unique position in bifurcation because you really simplify the procedure, especially for a complex bifurcation. You don't have to think about multiple steps of wire recrossing, kissing balloon, pot, and so on. On top of that, you can reduce the number of metal burden and promote vessel remodeling. The DCB can be utilized either as a DCB alone, the so-called puristic manner, or as a blended or hybrid, whereby you combine DES in the main vessel and DCB in a side branch. One other interesting thing with DCB is you can treat the main vessel, and yet you have some effect on the ostium or the side branch. Here again, work from Professor Shin, you see that just the DCB treatment of the main vessel, over time, you look at the second panel, the side branch opening gets larger with time. There are a number of meta-analyses looking at the smaller data together. With regards to side branch treatment, the DCB is definitely better than plain old balloon angioplasty in terms of late lumen loss. The DCB BIF trial from Dr. Chen in Nanjing basically is a bailout situation where you have a sort of a jail side branch and you want to compare between a drug-coated balloon and a non-compliant balloon. Again, you see a reduction in TLF with the use of drug-coated balloon. The SCAAR registry also has a good number of patients, nearly 1,500 patients in the bifurcation subsets using DCB as a standalone therapy or a hybrid procedure in a blended procedure. Here you see once again, very reassuring low numbers of new myocardial infarction and low event rates seem to be on a better trend compared to the other DCBs. I'd like to share with you 1 or 2 cases. Here, this is a patient that was done not too long ago. You can see a very critical disease in the ostial left main, and in the other view also a very critical disease at the ostium left circumflex. Here you can see again, very tight at the circumflex especially. So the right has nothing very much. So in this case, we will then wire very gently across non-selective wiring, and then we try to create some channel of flow in the left main by using a balloon. This is after the wiring. We use a 2.5 balloon just to create some space and flow, after which then we try to wire. Wiring the circumflex wasn't easy because of the angulation. That already gives you an indication that if you were to do a complex 2 stent strategy, it might be sort of troublesome. And then after that, we optimize a bit further the ostium of the left main with a scoring balloon before we switch our attention to the circumflex. Pre-preparation with a 2.5 balloon. We had an IVUS after that. The 3.5 scoring balloon, this is the result. Some of us may be comfortable, but we are not here. We wanted to make it better. We sized almost 1-to-1 with a 4 NC cutting balloon, a scoring balloon NC, and this is the result. I think we were happy with that, and therefore we again proceeded to deliver DCB therapy with a PREVAIL 4x20, and it's the final result in the circumflex. And then we treated the left main to LAD with a crossover stenting with a Megatron. There's mild recoil, but there's good flow. We accepted the results. So it really has simplified the procedure instead of doing 2-stent strategy, and then we can always come back if there's a restenosis with a second stent in a later follow-up. The blended approach is seen. This is actually shared by Dr. Scheller at EBC just last weekend. The LAD diagonal lesion, he pre-treated with a 2.5 balloon, and that was the image on the left. Definitely, most of us would think that it's not well prepared. Went further with a scoring balloon 3.0, and that will be a good lesion preparation before individual sort of treatment with a DCB. If you intend to treat the side branch, always treat that first before you implant the stent. You try not to cross the DCB across metal struts as the final results. So friends, at DCBs today, I think we accept that it's really novel. It's easy to apply in our strategy for PCI. From the outset, it is never meant to replace DES. It should be part of your strategy. If the vessel preparation is not good, just put it aside. It's just part of the sequence of the strategy. The decision for us to consider DCB is because of the concept that we should leave nothing behind and then avoid the problems related to the stent, and we have a potential for vessel positive remodeling. And we have seen that it can lead to many potential applications in other more complex subsets. But we must remember that we have to adhere to the good principles of vessel preparation before we even think about DCB. So we've got to relearn some of the POBA techniques. Once again, not all DCBs are the same. Selection of your DCB should be based on data and the technical advantages of certain specific DCB platforms. Large SCAAR registries, the real-world complex patients tell us that there's a high DCB utilization rate, and yet with this PREVAIL platform, you can have consistent low adverse event rate compared to other DCBs. Thank you very much.
Thanks. That's fantastic, Kim Wee, and we really appreciate Kim Wee sharing with us with the work that the SCAAR registry has published, particularly for the complex real-world subset. I want to focus the discussion on the first talk a little bit more on bifurcation and calcified lesions for complex lesions. But any questions, burning question from the floor for Kim Wee, or any questions at all? First, if not, maybe I direct the first question since Sydney is right beside me at Sydney. Then I saw the technique that beautifully done the case, both calcified as well as bifurcation, and Kim Wee applied the DCB before the provisional stenting. What is your advice to the audience about when do you actually, which step in the bifurcation lesion do you apply the DCB? I hear in my Thai colleagues, they want to apply DCB later because they are very afraid that they need a bailout and they wasted the DCB if they need to do a stenting because it's costly. But Sydney, maybe you can share with us your...
So I think the bifurcations are complicated in the sense you can do it so many different ways. And I think that DCBs, of course, you can leave the whole bifurcation without a stent. And most people have, I think where we are, trying to make it simpler in a sense. If you satisfy in any bifurcation, particularly left main, a complex bifurcation like definition 2 criteria, long extension, calcification, etc., then maybe you should just execute a 2-stent strategy because you know you can finish that case without any complicated decision making if you can't make a decision. But you can troubleshoot that 2-stent strategy really well. You can perform it. I don't think we know the evidence for applying DCB before a stent goes in and about the sequence of side branch, main branch. Some people put a stent in the main branch, a hybrid approach, provisional, and then treat the side branch ostium with a DCB. Very reasonable. There's not a lot of data against it. Well, they worry that maybe the stent may be shielding part of that or maybe difficulty getting a non-deliverable DCB to the ostium. Then treat that originally before the stent goes to the main branch. Also reasonable. There's a bit of choice, not data-driven. It's about comfort levels in the bifurcation PCI. But if it's complicated, I would still recommend a dedicated 2-stent strategy, easy to execute that you know, as an operator, you're comfortable with, get an excellent result really quickly, do imaging preferably, in my mind, as I do 100% imaging, and deliver that. If you want to treat now, I think contemporary acceptance may be 1-stent strategy, and then DCB the side branch. I don't know though, I know I would apply before or after, probably just do after for simplicity. And with the deliverability of Prevail, we've been doing that too, just Prevail after for the ostomy side branch, imaging main branch.
Thanks, Sydney. Narrative, maybe you share us in Thailand, when you do a DCB side branch, when is it done? Just a technical part.
I think it might be my personal practice, because I think as per the consensus, they recommend to treat the side branch first. But for me, when you get good DCB, you know that it's gonna cross anyway. So I think you can treat it as a last step. I mean, because I think in the old day, when the balloon was quite bad, the old day that DCB was worse than drug-eluting stent, people recommend to treat the side branch first. But if you have better DCB, why not later?
I want to add one thing, is to balloon the side branch ostium before the DCB goes in. I think you should try before you buy, because that's an expensive device. You use a balloon, dilate it, and so you can try that first, and then the DCB.
Yes.
Otherwise, I think.
Yes, I agree with your practice. With the use NC balloon, if it can go in, Prevail will go.
I agree. This is probably a less evidence kind of territory, and each one would have their individual preferences. But the recommendation came about because of the concern of loss of drug on transit, especially you have to go through stent struts. I've discussed with like Professor Chen when he did DCB. He's had some bench data to say that there's actually very little loss of drug in transit if you have opened up well. And yet I have also met recently Azim Latif actually discussed the situation where he did virtual heart. He actually saw drug shedding every time you pass through the metal struts. So it's all out of that concern. But I think that if you can deliver, we just want to make sure that we get the right dose, we don't lose as much as possible. But again,
the thing I've noticed too is, theoretically speaking, there's a lot of drug in the folds of the balloon, and so they are less prone to loss. Two is that when we do imaging, both on OCT and IVUS, you will see almost like a stent there, meaning that you see deposits of drug on the endoluminal surface.
Yes.
And that's a real signal to me that I've actually landed some drug on the surface. Yeah. So I think it's a very positive reinforcement for me. Okay. And those who have not done it, if you do imaging, you will see it looks almost like a half a stent. But it's not a stent, of course, you never put one in.
Maybe I'll move to Anurup then for the imaging questions, because I must say I don't have as good as imagination as Sydney. I can't see the drug on imaging yet. But Anurup, I want to deviate a little bit to the calcification, because also in the same case, you saw a lot of heavy calcification, right? Do you think in the current DCB technology is also well suited for calcification in two parts? Whether it is more effective after some form of debulking or atractomy, and what type of imaging should you not do for DCB approach?
So I think that the DCB is just only give the drugs to the tissue that can penetrate to the tissue. So it means that we cannot penetrate to the calcium. And especially for the bifurcation, I think we don't have the randomized control trial. If you redesign the randomized control trial, pre or post, it's very easy and follow up the clinical result, but the case selection is different, because we cannot predict the left main bifurcation, the ostial circumflex is very difficult to predict the outcome. So for me, it depends on the case. If we have the calcium, we try to do our best to have the crack or some dissection that we have the drugs inside the tissue. And after that, we will think about the complexity, angle, and many things that we can do the delivery, the DCB to the side branch, because sometimes when the DCB will working well with the times to penetrate to the tissue. If you cannot, you already have the DCB on your hands and you cannot deliver it. Sometimes it's not possible to do the DCB over the rep main because you need time to penetrate. So that's why I think that the technical is depend on the case.
Okay. And Frankie, maybe your choice. Which imaging modality do you prefer when you do DCB? Doesn't matter, or Is
Yeah,
there a preference?
I think it doesn't matter. So of course, for calcified lesion, I would say that OCT have a better idea of the thickness of the calcium, and also for stent failure, of course, OCT have its edge. But I think on the whole, I think both OCT and IVUS are very useful. Right? For lesion preparation, we can size the vessel. We're confident that we have a good luminal gain. And although we see a lot of dissections, but as long as the flow is okay, less than limit to type B or A dissection, I think DCB will be very, very useful for most lesions.
Any questions from the floor? I see a lot of experts in the audience as well. Any questions or comments or teaching comments?
Maybe just one more tip is we advise not to do a kissing drug-coated balloon. This
Why
makes
is
no
that?
sense. One, you have two kissing DCBs together, there's going to be interaction, you're going to lose some drugs. When you have two kissing at the proximal main vessel, there will be gaps. You don't have actual coverage of all the lumen. So sequentially one, and before you kiss, you deliver the drugs first.
Yep.
Kim, can I ask you, have you done just DCB alone for bifurcation?
Not the left main bifurcation, more for data and also for comfort and plus legal implications. But I think if you prepare well, like what Prof. Scheller did, you get almost 10-like preparation results. I'm very comfortable to put DCB.
And since you showed the case, do you necessarily have to use scoring balloons before DCB?
Okay, I think it's a good technical point because you want to make sure that you create some dissections, but you don't want to have uncontrolled dissections. Scoring balloon, cutting balloon gives you that control. And when you have dissections, if you've seen very clearly, the more dissections you have, the worse the dissections, actually the outcomes are better. The lumen gain is actually better because theoretically you get more penetration of drugs to the vessel wall when you have those cuts.
Okay, I think we're going to move to the last lecture, but before we go, let me ask Sydney, how long do you put the DCB balloon up?
Well, actually, that's in the IFU. I think at least a minute would be good, but you can get away with something like 30, 40 seconds. Now, sometimes in your individual patient is a tolerance to ischemia. Obviously, I don't do DCB for left main, but some people have. And so if even ostial circumflex, if you're sticking out in the left main, protruding the left main, you can still get some ischemia. So some people don't tolerate ischemia very well. So at least 30 seconds, but preferably a minute. I think we used to go 120 or more with a sequent please, but I think they're hard to deliver. And so we've shied away from using them now.
In that case, the circumflex you showed, how long do you put the balloon up?
He could tolerate up to 1 minute. So sometimes you do a bit of ischemic preconditioning and then tolerate better.
Okay, so I guess longer the better. I've seen someone say 3 minutes at least, but it's variable. So thanks a lot for that great discussion. We'll move to the other exciting case now, presented by Frankie. Yeah. Frankie is going to talk to us now on the different subset, on the ACS subgroup for DCB use.
Yes, thanks, Jack, for the kind introduction. So I'm Frankie Chen from Hong Kong. So the topic today is from adoption to advocacy, prevail evidence journey. So here my disclosure. So I think every one of us here are actually using a lot of DCBs, and nowadays we know that we're expanding indications. In the past, we use it for small de novo lesions or in-stent stenosis. But nowadays we are doing bifurcation, ACS, STEMI, CTOs, large vessel, and also some people, the young patient, diabetic, HBR patient, depth, duration. All these are the issues that we are talking about for DCB, and I think we'll be having more and more evidence on all these topics in the coming future. But of course, because of time constraint, in this talk, I would like to concentrate on the use of DCB in ACS and STEMI. So for DCB and ACS and STEMI, theoretically, it's good, right? Because we leave nothing behind, allow the vessel to be modeled. But at the same time, there are some concerns, for example, presence of thrombus. Will that affect the DCB efficacy? I think this is the thing that in the future, we'll be having more and more evidence to explore it. Of course, nowadays we are talking about the evidence, right? Of course, the SCAAR registry, as explained by Dr. Chu in his previous lecture, is a big group of patients receiving DCB and the good evidence, right? And mind you that in the SCAAR DCB registry, there's a lot of patients actually are from the ACS subgroup, right? So in the ACS subgroup, right? So actually, a lot of those patients are using DCB, and we can see they use some use PREVAIL DCB and some use other DCB. Of course, and you can see that these are the baseline characteristics of this patient. Mind you that actually a lot of them are even having a STEMI, that is acute STEMI visual occlusion, that in this study, in this registry, that DCB can be having very high procedural success and very, very low complications rates. You can see all these patients, right? STEMI, multivessel disease, diabetic, and all these are complex patients, and many of them, right, having type B to C lesions, bifurcation, and the procedural success is approaching 100%. And here are the outcome data of all these patients. You can see that these patients are, although a very high-risk patient, ACS patient, even STEMI patients, they're having what we call a acceptable risk of mortality and also adverse outcome. And you can see that comparing PREVAIL and other DCB, the mortality, new MI, TLR, and also thrombosis are actually in a very, very acceptable rate. And so when we also look just at the STEMI, actually in this registry, it's interesting to look that PREVAIL DCB actually is having a better outcome than other DCB. Of course, these are hypothesis generating. We're looking forward to more and more data regarding the use of different DCBs in ACS, especially STEMI patients. Again, very low TLR, very low target lesion thrombosis in ACS patients using DCB. So the key takeaway of the SCAAR registry is that in patients with ACS, PREVAIL DCB can demonstrate very low mortality and revascularization rate. Even in high-risk patients, the STEMI patients, the PREVAIL DCB demonstrated very, very low event rates with only 1.4% new MI at the first year. Right? And so nowadays, PREVAIL DCB is approved for the treatment of patients with ACS, including STEMI. Right? And these are is supported by the data from the ACS STEMI subgroup from the SCAAR registry. And I can assure that in the coming future, we'll be using more and more DCB for ACS or STEMI patients. Of course, we need more data, and the PREVAIL global study is underway. I'm lucky that in my hospital institution is one of the investigation sites here. So in this study, actually, they divide all the patients into two subgroups. One is the ISL cohort, right? For ISL cohort is RCT, randomizing patient into PREVAIL DCB and Asian DCB, which is the only one currently approved in the US. So this is an ISL randomization cohort. For the de novo small vessel cohort, we are mainly targeting vessel of 2.0 to 2.75 millimeter, and this is the registry cohort, right? So hopefully in the coming future, we can have really randomized data to comparing use of different DCB in the ISL patient, and also we can have the data for de novo small vessel cohort in a prospective registry manner. And for the bifurcation stuff, as explained by Dr. Chu in the previous speaker, and we are also doing some study, right, on this bifurcation and DCB. So this is the DBC DCB study, right, comparing patients with DCB only and the stepwise provisional approach. So of course, in the coming future, this study, again, will provide very, very important evidence for us to guide the usage of DCB or hybrid approach in the treatment of bifurcations. So to wrap up, I would like to present a case of ACS and STEMI but in use of DCB. So this is I would say a little bit controversial case, but again, this is a very practical and can happen in our daily practice. So this is a 76-year-old man, smoker. He has a newly diagnosed lung cancer, pending treatment. At the same time, he complained of on and off rectal bleeding and also melena in the coming few days. However, he complained of acute onset of chest pain for 2 hours. You can see the ECG actually showed acute intraproximal STEMI. You can see ST elevation here, and ST depression in the V1 to V3. And the echocardiogram showed EF of 20%, intraproximal hypokinesia, blood pressure borderline, a little bit tachycardic. Patient is obviously in distress and pain. Examination, rectal exam shows the O melena. And the point of care hemoglobin showed hemoglobin just 10. So in this case, acute STEMI, symptomatic, relatively stable, right? And at the same time, probably acute GI bleeding. So how will you manage this patient? Will you just keep on medical treatment? Will you proceed to coral and PCI? If you want to do coral PCI, what is your antithrombotic strategy? Aspirin, P2Y12, PREVAIL-12, clopidogrel or ticagrelor. And obviously, thrombolysis obviously is not an option here, right? Because patient is having an acute GI bleeding. right? So we take the patient to cath lab, right? We first perform the angiogram first. So we give the patient aspirin, but just do the angiogram. You can see that the left side is okay, TIMI free flow, some stenosis in the circumflex, already moderate stenosis. And this is the RCA. Okay, you can see there's a critical stenosis in proximal RCA with around TIMI 2 flow, right? So what will you do, right? So this lesion can account for the acute infiltrative STEMI. But what will you do, right? Patient is having continuous chest pain at the same time, possibly acute GI bleeding. Will you do PCI? If yes, what is your antithrombotic strategy? Right? So I think this is maybe a little bit controversial, but what we have done is that we proceed to the PCI. In this case, we just give aspirin, all right, and also heparin. We did not give any P2Y12. So we did not give any clopidogrel, we did not give any ticagrelor. So we do balloon dilatation, right? Of course, after balloon dilatation, you can see the flow now is better. The vessel go a little bit bigger, the patient symptom a little bit improved. Right, and then we proceed to have a better lesion preparation, right? NC 2.5, NC 2.75, and in this case, we choose to do a DCP approach, right? So this patient only aspirin, no P2Y12. We don't want to put in stent, and we didn't do imaging in this case because we want to finish the case as fast as possible because we did not give any P2Y12, so we don't want the device to drag in the patient's circulation, I would say, too long. So this is the DCP. And this is the final result, right? TIMI free flow, quite good looking. Okay, obviously after this PCI, the patient much better, right? Chest pain resolved, ST elevation resolved, and we consult the GI team. They have an OGD performed just 2 hours after the PCI. And the OGD shows us actually the active bleeding angiodysplasia in patient's stomach. They do some low hemostasis, right? Heat probe. And after discussion, right, we can give the patient clopidogrel, but without the loading, right? And the GI surgeon actually think that this may not be able to 100% explain the acute GI bleed of the patient. So we arrange a colonoscopy 1 week later, which showed diverticulosis and polyp with polypectomy done. And during the polypectomy, the clopidogrel was tempered with hold for 2 days. So ladies and gentlemen, right, this is the end of the case. So we plan to take the patient back when the GI bleed settle because we want to do the circumflex, and at the same time we will look at the RC and see how this angiogram showed. So DCB now emerged to be an invaluable tool to treat complex disease and complex patient. And I think that DCB indication is expanding. I would say that the use of DCB is expected to be increasing. Of course, we will need more evidence to guide our treatment in the future. So thank you very much.
Thanks, Frankie. Excellent case. Any questions for Frankie about his case from the audience or from the panel? Any comments or questions? Maybe I ask Kim Wee first because I saw in the Malaysian, their national registry for AMI, DCB use in STEMI is actually quite high. Maybe you can share with us why it has gone to the direction in Malaysia.
Okay, again, I think this is more of local culture and not much evidence. There are some evidence on STEMI and DCB, and again, the premise is that you want to make sure that you prepare the lesion well before you even consider DCB. And I think it's just a local thing that everyone's so comfortable with sort of ad hoc procedures in STEMI, they use it as well. Whether or not it's the right thing, I think is a question. If you have a lot of thrombus burden, is the drug going to be delivered enough to the vessel wall? That's again is questionable, right? The other thing is also, I think Frankie's case to me is a great case to illustrate the use of DCB for HBR. HBR, although we know that there are a lot of trials with specific stents and abbreviated DAPT 1 month to 6 months and so on, but if you have a case that you have put in a stent and then bleeds like this, you're going to be more comfortable if you haven't put in a stent. So I think this is a great situation where DCB actually is good to abbreviate the DAPT.
I think it's a great use case. I mean, I've asked our Malaysian colleagues, a few Malaysian colleagues why. They tell me a lot of reasons. I don't know if it's true or not. One is that the cohort in Malaysia for STEMI is pretty young. Quite a lot of smokers and diabetic prevalence is high. And they try not to put in a stent. The other reason is Malaysia is still a much larger country than Singapore, and some of them don't come back to collect their DAPT. So there's also a fear of non-compliance to DAPT after stenting. Yeah, so I think it seems a bit safer. It's worked quite well over the years. And the prevalence is as high as 40% of STEMI, just
Could be.
DCB alone.
And the numbers are increasing. In the
Numbers
last-
are increasing. So Malaysia has a lot of experience with that.
The other thing is that no stent means no stent thrombosis. Two is that physicians are much more responsible. If you put a stent in, I guess you're much more involved. It's your stent you've inserted, and if something happened to it, feel much more responsible. But the other thing is that you avoid if you're not doing imaging, you avoid a gross anesthetizing of the vessel if you're putting stents in. That's also probably advantageous.
Okay, maybe I ask another tip. Because Gimui mentioned thrombus burden, are you comfortable in high thrombus burden to use a DCB approach?
To be honest, I'm not comfortable. So I think when we talk about complex lesion, I think people with more experience tend to go further. I think for me, ACS is the last area that I would use DCB. I think I would treat it. It would be case by case, like the case that Frankie just presented. Perfect case to start with. But for me, sometimes in high thrombus burden, sometimes I do defer stenting. I bring the patient back and, after anticoagulation and take a look and see what happened. But I'm reluctant to do DCB in STEMI with very high thrombus burden.
Thanks for the comment. Anaruk, if you're going to use a DCB approach, do you tend to use more thrombectomy then?
So this case is just 2 hours, and I think the thrombus burden by angiogram is less. So I think that it's not necessary to do the thrombus aspiration. But in this case, like Dr. Narathip, DCB penetrated in our country just only 10% and just 1 or 2 years. For a long period, we still believe in stent because we can get the big luminal gain and get a better flow after we put the stent in. So that's why in this case, it's a straight vessel. It's quite a straight long vessel. With that, the diameter is also big. So we feel comfortable to put the stent, and maybe we can talk about 1 month DAP and just the flow is enough. But it will be better to have a DCB in the shelf and try to prove the concept of the DCB in this situation, because we cannot know that the breathing for the patients can tolerate or not in some situation. But we have to wait to see the data.
Any comments or questions from all your experience sharing on this subgroup?
Yes, please.
From the population? Yes, please. Maybe you can get to the mic so that everyone can hear you.
How do you size a DCB when you have size discrepancy? Distal vessel 3, proximal 35375. How do we take the size of the DCB? And second question is, how do we use DCBs in calcific lesions? Because in calcific lesions, DCBs may not work when you have significant calcium burden. So just question to the panel.
Thanks for the great question. Kimui, you want to try?
Okay, I can do the sizing one. So if you use intravascular imaging, fine. You know where actual sizes are. If you're going to use angiography, you look at the distal. As you said, they say you have a 3.0 and the distal mean about 3.5, approximately 3.75. It's okay usually to use a 3.5 in for the distal because you're not going to go high pressure. 4 to 6 hemispheres is actually fine. If you have, of course, 2 long lesions, then you may have to use 2 different sizes to accommodate. So that's generally how I do it. Calcium, anyone?
So for calcium, I think Anaru partially answered it. I just want to emphasize that heavy calcified lesion is complex, and we don't have enough data to support routine use of DCB. In general, the basic principle of DCB, you must have enough lumen gain, and DCB is just a balloon. There's no scaffolding. So you have a lot of dissection flap. You're not too sure where the drug reached behind the calcified lesions. There's a lot of recoil. There's more than 50%. You know your DCB approach may not be ideal. So our advice against just pure DCB if you have heavily calcified lesions. So that's not my first go-to unless you're caught up with really a high bleeding risk subset. Regards to my own personal preference for a STEMI approach, I am a bit like Narathip. I'm probably stand first for most STEMI, mainly for safety. You just want to do it, go home. But for the subgroup where I know that it's diffuse disease, I'm just treating a culprit. The patient still need bypass. I may consider a DCB. If then we can discuss. Yeah. And of course, a high bleeding risk. And the last scenario is really a high is a smoker, I tend to use thrombectomy. And if I see either with balloon or just thrombectomy, almost a normal artery, like imaging may help.
Yeah.
And maybe just a DCB approach if the lesion is not so bad after ballooning.
So regarding heavy calcification, personally, I use a lot of DCB, but I use imaging, and I use atherectomy devices plus specialized balloon, because one, you have to make sure that you get a lot of acute luminal gain, and you need to identify calcium fracture. And then I use DCB, but to be honest, limited data.
Agree.
Yeah, so he does a lot of prep work. You see a lot of cracks. You're quite certain that, and maybe you can wait a while. You have the lumen gain on pre-dil, then you wait a while, make sure there's no massive recoil or dissection before you put in a DCB. Yeah.
In ACS, sometimes you may use hybrid approach in the same vessel. Like for example, proximally, if there is large thrombus burden, big artery, you put in a stent, and distally, if there is a long diffuse disease, instead of putting 2.5, 48, 40 millimeter stents, we may use DCB to the distal vessel. So that is another, I think, extended indication of DCBs as a hybrid approach in ACS when we are not happy putting stent.
Yeah, totally agree. I mean, not just ACS, even for CTO, same, right? So we treat the CTO and then distal diffuse to DCB. So this hybrid approach probably is becoming more and more popular for DCB and DES together. Yeah.
Thank you.
But I appreciate your question because you're the only one to step out and ask the question, but thank you very much. Yes, last question, and we probably have to close the session. Thanks.
Are there any imaging criteria that DCB has done a good job, a good luminal gain? Like we have a MSA in terms of IVUS minimal stent area. Like though, is there any imaging criteria we can decide now we can leave this vessel with the DCB alone? We need not put a stent. And my second question is, we had a patient, 23-year-old smoker, obviously, 99% osteal LAD with huge thrombus burden. On OCT, we found a plaque rupture. So like the saying is that if there is plaque erosion, we can do a ballooning and we can leave it. And plaque rupture, we have to stent. So in plaque rupture also, can we leave it with the DCB or we need to stent? Because he's a young champ, 23 years old.
So
Yeah.
I think from the data from the Harbin group, they also do the OCT and just only do the aspiration and give the very potency medication. They start with the plaque erosion for the ACS. That is have a good result, even though in 2 years. And the second paper, they do the plaque rupture like this. And I think I can remember that is have a good result too for 1 year. So that's why we can use the DCB to make us more confirm that the ISR will reduce, even though we give the new generation medication like the potency antiplatelet or the new PY12, new the PCSK9 to reduce the LDL level.
If you have a type 1 MI plaque rupture, but there's no flow limiting dissections after you dilate, theoretically a DCB might work.
Yep.
But you have to have the gumption to use it and just wash a patient. Most times it works quite well, I must say.
Again, depend on your level of comfort. If not comfortable, these men just came in with a STEMI, put a stent.
Yeah.
It's part of the
Safety first,
strategy,
yeah.
right?
Yeah.
And the second question was imaging criteria for the DCB. Like,
I think maybe I just take down quickly in the interest of time. I think we don't have a formal imaging criteria for DCB use. We have a criteria to say that you have to have a large enough MSA before that. The imaging criteria that is confusing is whether what type of dissections is not suitable for DCB use. If you have medial tear, you have very hematoma forming, maybe those that need some form of scaffolding strength may not be so suitable for just plain DCB.
If you are the OCT level like me, you will see the very ugly thing inside the vessel when you do the DCB. Just only the angiogram, you can accept it and don't see it much in the OCT if you want to use the DCB in your case.
Take a look at pre-PCI OCT, but not post-PCI.
Yes.
So I'll go one step further. If I'm going for DCB first approach, I try not to use imaging. I'll go with the angiogram approach. Good angiogram technique will allow you to get a sense of whether the DCB will work as well without imaging. In fact, I get confused by the imaging, so I don't want to comment further. But thanks again.
End result is the clinical, not the
Yeah,
imaging.
it's a clinical end result. But thanks, I appreciate that question as well. So I want to quickly sum up. Thanks to the two speakers, Kim Hui and Frankie. I just wanted to say that I said it earlier, I really appreciate the Swedish SCAAR registry. It's quite real world. And you can see that there is, in fact, in a country like Sweden, there's very widespread use of real world DCB. And they are doing complex stuff with the DCB as well. And I also want to say that in that cohort of DCB use of 6,000 patients, almost more than a third is a Prevail Medtronic balloon. And we all know that you go to the equipment that you think works, especially for interventional cardiologists. Once you touch it, I personally think that the Prevail balloon works quite well because it's actually very deliverable, very low profile. It's really a big improvement. And I like the technology of the unwrapping or the drug hidden in the balloon folds. And I found that the efficacy has been great. I feel that paclitaxel is still going to be a difficult drug to beat in the DCB illusion profile compared to sirolimus. So I think it has all the right check boxes, except Medtronic probably need to improve the length for the balloon. Yeah. So once you get the length in, I don't need to open 2 balloons for a single lesion. But with that, I think the field is still evolving. I encourage folks to try it out because I know it works quite well, but you need to put safety ahead of everything else. If you're not comfortable and you're not sure, I think you should get a second pair of eyes to adjudicate. Some of my colleagues have done the twilight-like regime where they think that post-DCB, they switch them to ticagrelor rather than continue on Plavix. And of course, in the subgroup with high bleeding risk is a great strategy to reduce the duration of DAPT. With that, I thank you very much. I think everyone is eyeballing me to stop. So, thank you.